with infertility. Moreover, it affects mainly the young women, 64% are less than 30 years of age, affecting their quality of life, compromising interpersonal relationships, and often leading to depression. That is why endometriosis makes us a challenging disease. If we examine the relationship of endometriosis and fertility, 25 to 50% of women with fertility issues have endometriosis, 30 to 50% women with endometriosis are infertile. Infertile women are 6 to 8 times more likely to have endometriosis than fertile women. Also, the fecundity in endometriosis is quite low, about 0.02 to 0.1 per month in comparison with normal women of 0.15 to 0.2. And in this lecture, I want to give you a recent insights into the pathogenesis, some inputs about the current diagnostic modes that are coming to play, and about the recent treatments that are in the offering. Molecular concepts of endometriosis, Sampson's theory of endometriosis, retrograde menstruation, has now been extended to include endometrial stem or progenital cells which have been found in menstrual fluid as N-cadherin or SUSD EMS cells. Mullerian duct-derived inner myometrium undergoes abnormal caudal fundal directed contractions, causing retrograde endometrial waves, transport of endometrial tissue fragments into pelvic cavity in more with cases of endometriosis than normal women. Endometrial mesenchymal transition is the process implicated in progression but not establishment of endometriosis. In deep infiltrating endometriosis, mesenchymal epithelial transition occurs, causing E-cadherin overexpression, and that is why there are definitely three components of the disease: superficial endometriosis, deep endometriosis, and ovarian endometriomas. Somatic mutation and epigenetic modifications are considered the pathogenic process of endometriosis. Genome-wide association studies investigated the association between common germline genetic variants and endometriosis that include SNPs and provided strong evidence for the contribution of many genetic variants across the genome, and that is why it is more common in some families. Gut microbiota dysbiosis, that is the gut-brain axis dysfunction, which is becoming more and more important in endometriotic diseases as well as in other inflammatory conditions, has a contribution to make. Now, about the advances in diagnosis, laparoscopy with histology is no more the gold standard. The potential for a range of non-invasive imaging methods to shorten time to diagnosis and to inform next steps in the treatment has resulted in their inclusion in clinical guidelines and clinical trials. As you all know, that transvaginal sonography leads a very important part in diagnosis of disease, especially in advanced cases, and in about 70% of cases of endometriosis, you can diagnose it with a good transvaginal sonography. MRI is specifically reserved to diagnose adenomyomas or adenomyosis and ruling out the comparison between adenomyomas and fibroids in uterus. Newer additions are ultrasound shear elastography and magnetic resistance elastography, which provides with the elasticity of the nodule so that you can plan your laparoscopic surgery better. Now, coming to advanced biomarkers, microRNAs. MicroRNAs are a class of small non-coding DNAs transcribed from DNA that play a vital role in protein regulation via interaction with mRNA and modulation of translation to protein, thereby having significant downstream effects on signaling pathways and cell behavior. mRNAs are secreted into extracellular fluid, which make them ideal target candidates as biomarkers. GWIC, a French biotech specializing in salivary RNA analysis, made an innovative non-invasive diagnostic tool named EndoTest based on the analysis of salivary mRNAs by NGS and by AI techniques. Genetic regulations of gene expression BCL6, endometriosis has been associated with aberrant cellular adhemal immunity. Studies investigating the changes in gene expression associated with endometriosis identified large differences in gene expression between utopic and ectopic endometrial tissue. BCL6 is a protein encoded by proto-oncogene present in chromosome 3 and that stimulates inflammatory cytokines such as interleukin 6, 8 and 17 in peritoneal fluid of women, leading to it forms a complex that binds to and inactivate regulators of the progesterone pathway, leading to progesterone resistance, aberrant decidulation, implantation failure, recurrent miscarriages, and in women with endometriosis. A new test has been found which is designed for receptive DX been developed to detect endometrial B6 overexpression in asymptomatic women with unexplained infertility or recurrent pregnancy loss, and this form can form a supplementary screening test with high positive value that can assist providers when counseling patients about all their options, including laparoscopic treatment of endometriosis before IVF cycles in particular. Organoids, microfluidic and CRISPR technology, the development of 3D organoid cell culture models using patient-derived cell allows the investigation of in vivo mechanisms in a preclinical setting. Endometrial epithelial organoids have been established comprehensive investigations into the development and pathogenesis of endometriosis. It retains the memory of the donor as shown in organoids derived from endometriosis and cancer patients. It uses microfluidic technology that offers a controlled microenvironment to reflect the cyclic human endometrium by responding to hormones of the menstrual cycle. The newly formed gene editing tools, that is CRISPR technology, to introduce or eliminate endometriosis as gene mutations can enable researchers to evaluate the significance of specific mutations and their potential to cause endometriosis. Last but not the least are plasma protein biomarkers. Our Australian study is in progress along with yesterday, and they have identified 10 different protein biomarkers, of which 4 has got positive correlation and the other has negative correlation in making a diagnostic test for early diagnosis of endometriosis in a non-invasive way. So these were the effects, the recent advances in the diagnosis as for screening of endometriosis, which is very important, particularly the young woman. Now, effects of endometriosis on human reproduction are mainly in 3 areas: pelvic cavity, inflammatory changes in peritoneal fluid, proliferation of macrophages and phagocytic dysfunction, release of pro-inflammatory and angiogenic factors, changes in peritoneal fluid can affect sperm-oocyte interaction. Uterus, activation of steroid factor 1 and aromatase, production of estrogen in situ, resistance to progesterone, changes affect endometrium itself. Ovaries, functional ovarian tissue, ovarian reserve reduced by endometriomas or by surgery, respond to controlled ovarian stimulation, hampered, and these are forms the basis of recent effects of endometriosis on human reproduction. The biological mechanisms that might link endometriosis infertility have been defined by A. Sadem. You also all know that at the advanced stages of the disease, the stage 3 and 4, distorted anatomy, altered peritoneal function, altered hormonal and cell-mediated function, abnormal uterine transport are the key factors. But recent light, especially from IVF studies, have shown that endometriosis results in endocrine and ovulatory abnormalities, compromises oocyte and embryo quality, and impairs implantation. Thereby, the results of fertility in the case of endometriosis with IVF is lower in comparison to one suffering from specific tubal disorder. Endocrine ovulatory abnormalities are unruptured luteolus follicle syndrome, impaired follicle, impaired oocyte morphology in women with endometriosis may have an adverse impact on the fertilization rate. Coming to embryo quality, in study of human oocytes exposed to endometriosis from women with early stages of 3 and 4 disease, it is shown that embryos with increased cell fragmentation occurs, altering blastomeria division, increased incidence of aberrant development of embryos, more prevalent nuclear and cytoplasmic impairment, cytoplasmic fragmentation is more common, and uneven cleavage in the endometriosis zone. But having said that, once the embryo is fertilized, when the oocyte is fertilized, there are 2 schools of thought whether the embryo quality is affected or not by endometriosis. Implantation is definitely affected by changes in receptivity in endometriosis. Delayed histologic maturation or biochemical disturbance may lead to endometrial dysfunction. Reduced endometrial expression of the alpha-5 integrase, a cell adhesion molecule due to the time of implantation. Very low levels of an enzyme linked to synthesis of endometrial ligand for L-selectin, a protein that coats the trophoblast of the surface. Functional disorders due to the presence of ectopic endometrial tissue and aberrant abnormal uterine contractions are some of the factors which can lead to impairment of implantation in a case of endometriosis, and that is why it is said that give GNRH treatment before you do a frozen embryo transfer in cases of implantation with endometriosis. With this idea in background, we come to the current topic, that is endometriosis, current insights. And at this point of time, I thank Corona and Dipesh and Vijay in particular for giving me a chance to speak in consecutive Corona 44 seminars. I am highly obliged and thankful to them. There is a paradigm shift in the diagnosis and treatment involving endometriosis beyond solely relying on surgery towards a more comprehensive approach that includes earlier, more accurate diagnosis through critical history, physical examination, imaging, alongside a wider range of medical and surgical therapies, including non-surgical treatments, and that helps in planning the treatment. The principles of treatment today, in the past, surgery was considered the definitive treatment of endometriosis, but recent evidences show that it does not solve the pathogenic mechanism and patients need a long-term management. Treatment goals are pain control and fertility improvement, maximizing the use of medical treatment, but also preventing post-surgical recurrence of symptoms, lesion recurrence in order to avoid repeated surgical procedures. In fact, surgery in women with endometriosis is associated with high risk of urological, intestinal, vascular and neurological complications, and pain may recur because of persistence of disease in case of incomplete excision of endometrial lesions, which is a common cause. Presently, medical therapy is considered the first line of treatment for most of the women with endometriosis to improve their symptoms, but also to plan the most adequate timing of surgery or assisted reproductive technology treatment, or to prevent post-surgical disease recurrence. The choice of most appropriate therapy is based on the intensity of pain, age, desire to conceive, but also on the impact of the disease on quality of life in each patient. So this is in short a nutshell of the management. Previously, surgery was the mainstay, followed by repeat surgery if need again. Now, medical treatment long-term is needed, followed by one definite surgery or PNART, and then you follow the final treatment with medical treatment once more. So clinical management of an infertile couple should take into account the age of the female, the duration of infertility, male factor, duration of medical attention. Because a few randomized controlled trials have been conducted to evaluate and compare the effectiveness of various forms of treatment. Current guidance in the drugs used in endometriosis, there is a host of drugs, of which 3 I am going to discuss, which are specific for the treatment of endometriosis. GnRH agonists, all of you know, are like diplomat, triptodin, so and so forth, work by initially stimulating the release of GnRH, leading to a temporary surge in the estrogen. However, they then downregulate the pituitary gland, causing a long-term suppression of estrogen production, which is crucial for managing endometriosis. They are typically administered by intramuscular subcutaneous injections. Side effects include hot flashes, dryness, so on and so forth. Initial surge in estrogen can cause worsening of symptoms that is cleared up during the first few weeks of treatment. And to mitigate the side effects, you can supplement by add-back therapy or hormonal therapy. Next comes diagnosis, which is a 4th generation progesterone specifically designed to treat endometriosis with high selectivity for binding to progesterone receptor. It has immune, anti-angiogenic and anti-proliferative properties and is effective in reducing endometriosis-related pain symptoms. The treatment guidelines of some countries recommend it as the first line of drug for long-term treatment. However, there is currently no scientific evolution on whether dinogestrel has a good efficacy or safety for deep endometriosis treatment. At present, there are relevant limited studies and the sample size are also a bit small, but overall the Japanese and the German collaborative studies have shown that dinogestrel can be used for a prolonged period of time, even up to 2 to 3 years. The new kid in the block is Elabolix, the oral GnRH antagonist. Is an oral that is used and approved by the FDA for the treatment of endometriosis, including pain. Through blocking endogenous GnRH signaling, Elabolix suppresses LH and FSH, you all know, thereby reducing estradiol and progesterone production. Recent studies have shown that it effectively suppresses ovulation, during controlled ovarian stimulation cycles as efficiently as the injectable antagonists. The beauty of this drug is the estrogen threshold hypothesis. You can start at a higher dose of 200 mg twice daily, reducing the dose to 200 mg daily, or for a longer term, maintaining at 150 mg daily. Your whole objective is to maintain the E2 levels between 20 and 50, depending on the symptoms of the people, and that is a great achievement in prevention of the bone health of the woman in case of long-term treatment. Comparing elevonics and dinosterol, Gupta and all did a prospective study of 340 women where they showed comparable efficacy in terms of pain relief in cases of elevonics and dinosterol. Elevonics has impact in BMD changes, which can be avoided by lowering the doses, but has no pro-thrombotic effect unlike dinogestrol. Now, we use elevonics in 4 situations. Prior to surgery, classically done using long-acting depot or GnRH, which suppresses the HP axis, thus leading to reduction of pain and vascularity and helps to delineate the surgical beds. Elevonics is demonstrating reasonably good outcome in conversion to GnRH agonist and through large trial is not available right now. Our experience to use the drugs 2 months prior to the surgery, then your surgery becomes easier, blood loss is less, surgical pains are easy to maneuver, and after the surgery, the lady has got a brilliant chance of conception. Can be used with controlled ovarian stimulation, where instead of the injectable GnRH antagonist, we use the elevonics as for prevention of the LH surge in a dose of 200 mg twice daily, once daily, or 150 mg, depending on the number of follicles and the E2 levels, and you can continue the treatment till you do the worm pickup. And in case of polycystic ovary, you can continue the drug throughout the time so as to prevent the notorious syndrome of ovarian hyperstimulation syndrome, and that is one of the specific areas where elevonics can be used in future years to come. IVF pre-treatment with elevonics, GnRH depot, as you already know, was widely used to suppress the HP axis, thus leading to better embryo implantation and pregnancy outcome in infertile women with endometriosis and adenomyosis undergoing IVF. Because many patients complained about intolerable menopausal symptoms of this 3-month regime, elevonics come to mind as a possible alternative. There is a trial currently going on, pregnant pre-IVF treatment with the GnRH antagonist in women with endometriosis, a multi-center prospective trial that is going on, and that is comparing the effect of elevonics pre-treatment for 8 weeks in women with endometriosis before undergoing IVF. On the other way around, before endometrial preparation, elevonics can be used for a long time, and then you plan your frozen embryo transfer. The effect trial, which is currently going on with subjects having prior unexplained IVF failure with positive endometrial BCL6 expression, using randomization with elevonics 200 BD or OCP for 2 months prior to standardized FEP, the primary outcome is set for a successful pregnancy. We have been using elevonics for a long period of time for this purpose before we plan our frozen embryo transfer in case of segmented IVF in endometriosis. Medically assisted reproduction, as you all know, is the first line of treatment in cases of ASRM stage 1 to 2 endometriosis. Intrauterine insemination with ovarian hyperstimulation is suggested instead of expected management or IUI alone. IUI with ovarian stimulation within 6 months after surgical treatment is a justified treatment and gives good pregnancy rate. Value of IUI in stage 3 and 4 endometriosis with tubal patency is uncertain, but IUI with ovarian stimulation can be considered, especially because of economic constraints and in good tubes with good band factor functions. Most used drug is gonadotropin, or you can use combined letrozole with that. Anti-estrogen therapy, as I said, clomiphene citrate or letrozole can be optional based on the indirect evidence from studies of unexplained infertility. Surgery, operative laparoscopy could be offered in stage 1 and 3 and 2 endometriosis as well as in endometria, as it improves the rate of ongoing pregnancy. Although no compelling evidence exists that operative laparoscopy for deep endometriosis improves fertility, operative laparoscopy may represent a treatment option in symptomatic patients wishing to conceive. The decision to perform surgery should be guided by the presence or absence of pain, patient's age and preferences, history of previous surgery, presence of other infertility factors, including partner semen analysis, ovarian reserves, and the endometriosis fertility index. These are the things we must consider before planning a surgery. And remember, surgery should be one definite surgery and not a repeat surgery once more, aiming at complete exclusion of the disease or excision of the disease and restoring the pelvic anatomy as much as possible. Avoid excessive cauterization. Avoid removal of small endometrius less than 4 cm because it impairs ovarian reserve and ANH. Prefer cyst removal in bigger endometriosis, keeping in residual healthy cortex. Use of adhesion barrier preventing barrier should be used. Success depends on completeness of disease removal, and no recurrent disease should happen after a complete surgery is done. Now, ART in endometriosis, ART can be an option in endometriosis, especially if tubal function is compromised, if there is male factor infertility, in case of low EFI, and or if other treatments have failed. Both antagonist and agonist protocols can be offered based on patients' and physicians' preferences. Can be reassured regarding the safety of ART since the recurrence rates are not increased. Segmented IVF, that is freeze-on using GnRH depot or an antagonist can be used before embryo transfer. That is the recommended in cases of endometriosis. Endometriosis has a decreased per cycle conception rate in comparison to male factor and unexplained infertility that has to be specifically counseled to the patient. Ultra-long protocol is an option when agonist is used. But it's nowadays more preference is used to the GnRH antagonist protocol. Things to be remembered during oocyte retrieval. It is technically more difficult in cases of endometriosis. Chance of progression of endometriosis and possibly